Well, greetings, everyone, and welcome to the March issue of EMedHome's EMCast. This is Amal Mattu at the University of Maryland School of Medicine, and this month we've got three really great hot topics for you. We're going to kick things off with an update on cardiac arrest. There's an article published just recently in Annals of Emergency Medicine called Improving Survival from Cardiac Arrest, a review of contemporary practice and challenges, and I will bet that this is another one of those impending LLSA articles for all of you that are ABEM board certified. This is something that you're going to have to read. So you might as well just listen to this podcast because we're going to hit all of the key topics from this very recent review article from December 2016. Then we are going to spend some time talking about blood culture utility, something that I think we take for granted in the emergency department. We get a lot of blood cultures on a lot of patients. Probably a lot of them are unnecessary, and we know it. But what are the consequences of unnecessarily getting blood cultures? Well, there's a huge financial consequence for one thing that I never knew about until reading this article, and there's some other consequences as well. Also, what are the consequences of not getting blood cultures in the appropriate patients? So we're going to talk about how to get blood cultures and also in which patients you are supposed to get blood cultures. And then we're going to wrap things up by talking about another hot off the press topic, the new sepsis guidelines just recently published in the critical care literature, which all of you, I'm sure, are going to be hearing about very, very soon. This hasn't even been published in any of the EM journals yet, but sure enough, it will be soon. So check it out. Anyway, let's go ahead and get started with this month's issue of EMCast. There was a recent article published in Annals of Emergency Medicine on improving survival from cardiac arrest. The article was from Mayo, and it was written by 5 people, actually, only one of whom was an emergency physician, unfortunately. 3 were cardiologists, 1 was an anesthesiologist. But it was a nice article, and it might be one of those articles that shows up in the LLSA. Of course, cardiac arrest is always a hot topic and something that all of us in emergency medicine are interested in. It's one of those cases that when you hear cardiac arrest coming in, high fives start going around and everyone's getting all set. You know, certainly more so than we hear an ankle sprains coming in. But anyway, I thought it would be great to get through this article. It was published in December 2016, so not too long ago. And joining me to get us through this article are 2 real, true experts in cardiac arrest and resuscitation. Mike Winters is here. You've heard Mike a number of times. And Rory Spiegel. Rory did a resuscitation fellowship last year and is joining us on faculty for a year before he heads off and does another fellowship in critical care. So who better than these 2 gentlemen to discuss this article? So Rory, Mike, thanks for joining all of us back at EMCast.
Thanks so much, Amal.
Yeah,
well,
thank you. I'm happy to be here.
Every one of the questions I'm going to ask you could probably, as we said offline, result in probably a whole half-hour discussion. But so we'll try to keep things moving along because I think a lot of this is review. But there's some really great stuff that we'll talk about. And we'll just go through this step by step. So the article starts by talking about chest compressions, which clearly are important and absolutely definitive. There's no controversy or doubt that push hard, push fast is where it's at. Mike, I'm being a little extreme, I'm sure, but what do you have to say about that?
Well, I would agree. Certainly we can't say always or never. I'm sure there's some controversy somewhere, but I think when you look at any consensus guideline in emergency medicine, resuscitation, cardiology, they will stress the importance of rapidly initiated, high-quality compressions as being really one of the most important interventions for obtaining return to spontaneous circulation and ultimately improving neurologic recovery. So what do I mean by high-quality compressions? Certainly the guidelines would favor at an appropriate rate, so somewhere between 100 to 120, and you can choose whatever song or era you like for that.
I was going to ask you what song you usually sing. Is it the Macarena, I'm sure? I've seen you do that arm thing a few times while leading cardiac arrest.
That's directing traffic.
Oh, okay. Yeah, sure.
So 100 to 120 at an adequate depth, so we're talking about 5 to 6 centimeters, allowing for full recoil, which is important, avoiding leaning over the chest as that increases right atrial pressure and ultimately decreases coronary perfusion pressure, and then minimizing interruptions. I think that's another key thing that we need to focus on. We certainly want to limit any interruption, but as the recommendations or guidelines would suggest, preferably less than 10 seconds. So all those peri-shock pauses we want to keep to a minimum. And then as we continue to do and talk about point of care ultrasound, just being sure that we're not keeping the probe on that chest too long in terms of interrupting high quality compression. So even brief interruptions are going to thwart our efforts for return to spontaneous circulation. So minimizing any interruptions is going to be critical.
All right. They didn't really get into the hands-on defibrillation, but there have been a few articles in recent years talking about that. Any thoughts about that, just from outside the paper?
Sure. I think that it's reasonable to attempt hands-on defibrillation. The studies that are out there, primarily one of which I'm aware of, is more of a cadaver study. And certainly you get some transference of current. And so I don't think we can conclusively say or request our compressors to keep their hands on in every case. I think it's very much an individual decision. And if that's something that you support, then I would say you, in essence, be the one that's doing compressions during defibrillation. But I don't think we can say at this point in time the literature says that it's something that should be standard.
Yeah, I think most of the data looking at it is demonstrating that you can do it without getting electrocuted yourself. No one's actually showed that it adds any benefit to the patient, like you're achieving more ROSC when you do it. And most of the data on peri-shock pause kind of say you start to see decreases in the rates of ROSC when you have peri-shock pauses above 10 seconds or so. Mm-hmm. So the fact that, not taking your hands off the chest for 1 second while you apply a shock would make much of a difference, I kind of find it hard to believe.
Sure.
I think the take-home point is what we do now when you're clear, I'm clear, everyone's clear, and it's like you're going to drop a bomb in the room and everyone leaves, and there's that huge pause. That's when I think there's a clinical difference. So the concept of just quickly hands off the chest, you apply the shock, and you're back on the chest doing compression.
Right.
I think is the important take-home.
We do have some very enthusiastic students that are always looking for strong letters of recommendation. In case anyone from medical school here is listening, I'm just joking about that. All right. Well, what about devices? There's been a lot of talk over, I guess, at least the past 10 years about various compression devices. Mm-hmm. And a lot of articles have come out, some saying great, some saying no difference. Your thoughts?
I think it's a great question, Amal. And if you simply take the preponderance of the literature, that's going to state, or the literature says, that really there's no difference in outcome between conventional CPR and mechanical devices. Now, I am in the camp where I believe certain scenarios and settings that it is beneficial. You've got a single provider in the back of an EMS unit and a long transport time, and it is very hard amongst everything you're doing to maintain high quality compressions while you're bouncing around in the back of an EMS unit. And I think there are appropriate settings where these should be employed. Also during procedures, when you're coming in, and we'll get into this momentarily, but if you are at a place that is evolving with an ECMO program or an ECPR program, there are some protocols that utilize mechanical devices while patients are being cannulated. So while the evidence says that there is no outcome difference, I do think that there are scenarios where it would be beneficial. I don't know what your thoughts are, Rory.
I think there's a little bit of, a misinterpretation of the mechanical CPR data often. The data that has been done in all the randomized trials, and I think there's 4 or 5 of them now, show that there's no difference when mechanical CPR is added to basic or advanced life support, which makes sense, and it's kind of a misinterpretation of what chest compressions do. Chest compressions are wonderful and very effective at bridging you to defibrillation. But if the mechanical device arrives at the same time as the defibrillator, you want the defibrillator first, and you're not really adding much by adding more efficient compressions at that point. It's what happened leading up to that defibrillation that matters. Now, no one's looked at a mechanical device when you're talking about doing something else, bridging you to the cath lab, bridging you to the emergency department, bridging you to ECMO. All these things are a completely different question that I don't think anyone has fully looked at, and those are the areas that I agree with Mike. I think it might actually have some use.
Well, Rory, one of the major differences between advanced life support and basic life support is the use of airway and also medications. And as physicians, because we can give medications and because we can intubate, we have a tendency to want to do those type of things. And I'm sure that mindset's probably true for advanced paramedics versus EMTs. But what's the deal with these interventions? I mean, do any of the ALS interventions actually make a difference here?
So the short answer is no, but there is a little more subtlety to that. There's been two large...
No.
Right.
It's the way you say it, I guess.
It's all in how you pronounce it. There's been two large trials looking at adding ACLS to basic life support. The first is the Opals trial out of Ontario, where they basically, it was a before and after taking their BLS EMS system and adding advanced life support and seeing if it changed any outcomes. And the second was a randomized control trial, and I'm going to destroy his name, by Olatsvigen et al., which was published in JAMA in 2009. And this randomized patients to receiving an IV or not. So ACLS medications above chest compressions and rapid defibrillation. Neither one of these studies showed any benefit to the added ACLS over what we do in basic life support. So from this macro view, it doesn't seem like any of these medications really add much to basic life support. Now, there's a lot of discussion going into the individual medicine, and epinephrine has taken a lot of heat recently with these large kind of registry databases that have found that patients that get more epinephrine tend to do worse than patients that get less epinephrine. And of course, these are registries and not randomized, so there's a lot of bias there. The sicker patients, or the one in the rest longer, are obviously going to receive more epinephrine, so it's kind of difficult to piece that out. The best data we have was the Jacobs trial, and this was a randomized trial randomizing you to epi or placebo. Unfortunately, because of enrollment issues, it was severely underpowered. It found no difference, but it wasn't able to really differentiate a 2% benefit to epinephrine. The Paramedic 2 trial is underway in the UK right now, and they're planning on enrolling 8,000 patients. So I think that will give us the definitive answer of the benefit of epi, at least in this bolus dose fashion, which we use today. And then I think we have to dive a little bit into the antidysrhythmic medications, such as amiodarone and lidocaine. And I think the best data we have for this was the ALPS trial, which was published last year in the New England Journal, where they randomized about 3,000 patients in VFib or pulseless VTAC to receive either amiodarone, lidocaine, or placebo. And again, the short answer here is they found no difference. Some will argue there are some trends towards benefit in some subgroups, but the authors really had to go to a lot of statistical efforts to find those patients. So I think overall with ACLS medications, they've really been shown to provide very little benefit. If you are going to use them, it should be done in a way that doesn't get in the way of the chest compressions and the defibrillations and the stuff that we know matters.
Yeah, so... Yeah, lidocaine made a little bit of a comeback after 2000, where amio became the drug of choice for everything.
Right.
And actually back then people were actually being sued for not giving amiodarone. Wow. And then lidocaine's made a bit of a comeback, but it's come back to be shown that it's also not as good, or no better than placebo for the most part. So I guess if you want to use a drug that doesn't work, use something cheap.
Right. And something that's not going to drop your blood pressure, which you do get that.
Yeah, that's true. And that is one nice thing about lidocaine in general. In that study, there was some, you alluded to this, there was some argument that maybe in the patients that got the drug early, maybe with bystander CPR, so the people that got help really early, in those patients, lidocaine and amio may have been a little bit better than placebo, but only a little bit, if at all.
Right.
And then on top of that, there was no superiority of one drug versus the other.
Right, exactly.
And then again, that's all the data dredging that you've kind of alluded to also. So who really knows what?
Right. I mean, they have to do a per protocol analysis and then a subgroup analysis of a per protocol analysis, which in statistical methodology are two no-nos. And so to take 3,000 patients and require to do all that kind of analysis to find a difference probably means that if it does work, it's not adding much to your treatment.
Yeah.
So let me ask a question, Amal, kind of turn things around.
Yeah, sure.
Are we at a point with the state of evidence where we really should be either shocking, continuing high-quality compressions, and not administering medicines?
I don't know the answer with regards to epi early, especially early, because there's some studies now that have come out suggesting that maybe early epi is helpful and then late epi is actually harmful. We just don't know. Hopefully that Paramedic 2 trial will give us some answers there. For antiarrhythmics, I'm not a fan at all at any point. I don't know. What do you guys think? We'll take a vote. We'll declare the standard of care right here. So antiarrhythmics at all for cardiac arrest patients?
I'm not a big fan of antiarrhythmics. I'm also not a big fan of another medicine we didn't touch on, and that's bicarbonate. It seems to be routinely given closer to the end of any arrest that I've watched or observed, and I'm I'm just not in that camp unless it's a toxicologic issue.
Or hyper-K, I suppose.
Correct, yeah, hyper-K.
Yeah, so tox or metabolic, sure.
But yeah, I'm not a big fan of medications overall.
Yeah, I agree. I think they add a lot of complexity to the resuscitation themselves. And I think it does, no matter how much we try, take away from the things that really matter. I think if you're alone in a small ED and you have a refractory VFib patient and you have no access to ECPR, some of the more advanced things we'll talk about, sure, lidocaine and amnio is your only kind of next step in a patient that might be salvageable. But I think as we start to move forward in our thoughts on managing cardiac arrest, we should start to move away from these treatments that we have pretty good data that they don't really do much, and kind of move towards things that we know or think might be beneficial.
Yeah. I've gotten emails from people who have been running codes and withheld those medications, and then they get complaints from other members, the nurses or the techs, other members of the team.
I'm not surprised.
Yeah, and so there's a certain peer pressure, I think, to go ahead and give that. So I think, number one, we need to get the education more widespread. And then number two, what I have found helpful oftentimes is just ask the members of the team, does anybody have objections to withholding this or stopping? And that way you're at least incorporating them, and then do a little teaching there also to let them know why you're not. But if you don't address that up front, you're going to end up having to address it later on.
Yeah, I think that's a key point, because cardiac arrest is a team sport, and you're basically managing a whole team. It's not just you, it's not just the residents. There's a whole team there, and you sort of do get that feedback until you start doing that education. And now they know that I don't give very many medications, and no one actually kind of puts up a fight about that.
Yeah. There was one study a couple of years ago that talked about steroids. Steroids plus vasopressin plus epinephrine. Mm-hmm. And that was primarily in-hospital cardiac arrest. But I haven't heard anything more about that. So are steroids, despite that study, dead? Are you guys using steroids at all for cardiac arrest?
It's funny. It's two trials. There was a small kind of, I think it was about 50-patient trial to see if they could do it, and then they did this larger randomized trial where they randomized them to epinephrine and placebo, or epinephrine and vasopressin and steroids.
Right, and I think that was in JAMA, right?
Yeah.
So that's got to be good.
And it was a very positive trial. I mean, it was probably the most positive trial we've seen in cardiac arrest literature in years, and no one is doing it, and I can't decide if it's just none of us believe it, it's too good to be true. I mean, you have got pretty good data randomizing patients to vaso plus epi, vaso or epi, and no one ever found a benefit in much larger trials. So the question then becomes, is it the steroids that are making it different? These were all in patients, or in hospital cardiac arrest patients. Some of them were septic. Maybe there is some other issues going on. It seems like the patients that did better were the ones that got ROSC-on. So they didn't get more ROS patients, just the patients that they did get ROSC-on didn't rearrest, and they had more benefit there. So maybe the steroids, I kind of want more evidence before I change around my whole logistics to make that happen.
Mike?
There's an interesting study from 2016, Mike Danino out of Boston published. Steroids, actually, I believe it was in post-ROSC shock, that steroids actually was beneficial. It came out in critical care 6 to 9 months ago. That's something that we could possibly review on a different topic, since it's in the post-arrest patient. But nonetheless, that study was a benefit for steroids.
Yeah. And that might be the signal you're seeing
Sure.
in the last trial as well. Sure.
And with those being in-hospital cardiac arrest, who knows whether there was a lot more sepsis there or other types of things. I remember I had an attending in residency who, I think he really believed that nobody should ever be pronounced dead until after they've received steroids and magnesium. They did talk about magnesium in this paper as well, and really said there's no good evidence to support the magnesium also. The other ALS thing that we mentioned earlier, Airway. What are your thoughts about Airway, early Airway? Just go with bag valve mask ventilation? Do we need to worry about Airway early?
I don't think anybody knows the answer, in terms of ultimately the correct timing. I think it does get down to the specific patient and whether they're coming in with a primarily hypoxic cause of the cardiac arrest versus cardiac. We've talked, I think, at length on some other discussions about when patients first go down, they don't necessarily need ventilations, and there's discussion on that in terms of how to provide oxygen to those patients. I think after a few rounds of CPR and early defibrillation, it's probably the time to intervene. I don't have a specific point, but when you do make that decision, I do think, once again, getting back to minimizing interruptions, I found video to be a little bit more helpful with securing the airway during the course of compressions than DL, but that's probably variable experience. There's one article we reviewed that showed video may have a higher, actually not higher success rate, but less time hands off the chest when using video compared with DL. So.
Yeah, I tend to agree. I think Bobrow's data on the CCR, which is the cardiocerebral resuscitation, where he essentially ignored the airway and did compressions and defibrillation, is optimal upfront in the patients with a shockable rhythm. I think when you get into the patients who have PEA or systole, certainly some of those are going to be a respiratory arrest, and those ones are going to need an airway. Now, the question, what airway is optimal, I think we have no idea. I tend to use an LMA in my patients just because it kind of avoids all the issues of having to intubate, all the hands you need to bag someone. It's very quickly to place an LMA, and I can actually plug them up to the ventilator at that point, and let the ventilator do my bagging for me.
Sure.
So it kind of offsets a part of the resuscitation that I think is less important than the other parts that I want to focus on.
All right. Okay, moving on to even more advanced stuff. There's been a lot of discussion in the EM and the critical care literature about ECMO, or extracorporeal membrane oxygenation, or ECPR, extracorporeal CPR. At first I thought that meant online CPR, but no, so ECPR. So, Roy, you've got probably a bit more experience than most of us here from your resuscitation fellowship. And what's the deal with ECMO in terms of who should get it? And are there contraindications? What type of hospital? Any hospital should be using this, or just the big tertiary care centers? What's the story?
So I think some of us hope that at some point a lot of hospitals will be using it. Right now it's probably more the tertiary centers that already have ECMO services, so the translation into ECPR is rather small from the big picture. I think to look at which patients get it, to take a big picture, what we do know is chest compressions and defibrillation works great really early in the arrest. There's this wonderful paper published in the New England Journal in 2000 by Valenzuela et al., where they trained casino workers to identify people went into cardiac arrest, do chest compressions, and shock them. And because of the eye in the sky in all casinos, they were on them in like 2 minutes, and the survival rates were somewhere like 70%. I mean, these patients got up and wanted to start gambling again. But things start to kind of degrade from there. If you've achieved ROS before a hospital, survival rates are somewhere around 50% in the patients that actually achieve ROS before they get to us. VFib, VTAC, all comers, 24%. All comers in cardiac arrest is 9%. But the thing that often goes unmentioned is cardiac arrest is essentially a pre-hospital game. If you've reached us in the emergency department without achieving ROS, survival is somewhere around 1%. That is all comers who haven't achieved ROS by the time they've reached us. And essentially what this means is our traditional methods of resuscitation are just no longer effective. These patients have been in arrest for a long time. They've had these treatments tried on them already, so if they were going to work, they were likely to work the first few times. And at this point, we're kind of just using the same stuff over again and expecting to get different results, which I think someone defined as crazy. And so there are some forward-thinking individuals that are starting to look at different means of resuscitating these patients in what we call refractory arrest. And one of the big components of that is ECPR. And the concept here is when these patients arrive in the emergency department, you're going to get access to their femoral artery and femoral vein and put large bore cannulas in and put them on pump.
These are really large.
Really large. Well, it depends. The movement now is to make them smaller. It
really?
used to be when they first started were 21 and 24 French, which are, chest tube size.
Yeah.
But a lot of the forward thinkers in this field are now putting in 15 and 17 French because it's much easier to put that in someone with chest compressions going on. And you don't need full 5-liter flows in patients. To get them back, you need about 3 liters, so it's much easier, and you can get them on pump much faster. So that's kind of the movement is towards these slightly smaller, but large in respect to what we normally put in the emergency department. And then once you have these patients on pump, sometimes just that flow itself is now perfusing the coronary arteries, and then you get back ROS. Sometimes you've got to take them to the cath lab, open up whatever lesion caused the arrest, or they had a pulmonary embolism, but it buys you time to fix whatever problem is going on. Now, the patients that get it are kind of, there's different criteria, but it essentially is a patient who had a witness arrest, so didn't have a long period of time where they weren't getting perfusion to their brain. So CPR started almost immediately. They had CPR throughout the time before they got to you, and they haven't been down for more than an hour. And then after that, everything else is kind of like they can't be too old, and too old is a very relative term. They can't have any terminal diseases or anything else that you would be obviously not want to put them on ECMO and go through this whole process. But otherwise, you can see it's a very moving target, and as people get better at it and more comfortable, they do start to expand the limits of who they'll put on pump. Now, I guess the last question is, does it work? And we don't have really any good data for that. Most of the data are these prospective studies where we see that patients put on pump or who undergo ECPR do much better than those who don't. And that's really hard to know what to do with because the patients who were put on pump are obviously a healthier cohort than the ones who weren't.
It's a very select population.
Right. So it's a little hard to know. There is some more robust data coming out over the next few years, so I think we'll have some idea of what to do. I think what is clear is if they've arrived to the hospital in cardiac arrest, the traditional methods are really, really ineffective at that point. So just stacking one useless intervention on top of another doesn't actually get better outcomes. So I think we have to start looking to something else. ECPR seems to be one of the more promising interventions.
Okay. So by the time you get to that third dose of bicarb, you should have probably been thinking of something else. Now, you mentioned up to an hour. In the article, they talk about, this is something that you should probably be thinking about after, 15, 20 minutes or so. So that's kind of scary to think about. I mean, because by the time they get there to the emergency department, they've already been working on it for a good 10, 15 minutes. So this is something that you really, if you're going to do it, you need to get moving relatively early.
Yeah, so we're trying to move our program forward here, and I tell the residents that you almost know who you're going to put on pump by the box call.
Exactly right. Yeah, I would agree with that. Because it takes so many minutes to mobilize the team, get the cannulation done, and then start them on pump, that it's going to be up to that hour. So yes, the times that I've been involved, I've called from the EMS base station based upon age and asked them about comorbidities.
Right, and just knowing that the likelihood that you're going to do anything more meaningful through traditional methods is very slim. So you can, make the call, and when they get to you, see if there's any things that you can fix, identifiable causes of arrest that you could do something about as everything else is getting mobilized. But most of the time, you can make the call before the patient even arrives.
Well, give me an example of the call that you would get for which you would hang up after the paramedics call and then pick up the phone and call whoever to get ECPR going, or maybe tell the staff, all right, this is a person who's going to be arriving, and if they still don't have a pulse, we're going with ECMO. What would be an example of that?
So, 56-year-old male is a witnessed arrest in public, found to be in VFib, a shockable rhythm, was shocked 5 or 6 times in the field, unable to achieve ROSC, and has been down for 20-30 minutes at that point.
Okay.
So that is a highly salvageable patient who has been having a normal life before that point. I know if he arrives to me, the chances of me getting ROSC in the ED are very slim.
Yeah.
And he's essentially the ideal patient to put on ECPR.
So, okay, good. That's helpful, actually. All right. In the article, they move on right after ECMO and start talking about PEA, which definitely has become more and more common. I recall when I was in residency, we saw a lot more VFib than we see nowadays. And it wasn't because the paramedics were any faster, but there's some theories about that. Perhaps the increased use of beta blockers has cut back on VFib incidence, and I don't know what it is, but we are seeing, relatively speaking, a lot more PEA than ever before. And I, unfortunately, like most other listeners, learned about all those H's and T's. And is there a simpler way? Mike, what's your approach to PEA? What do the authors of this article talk about?
So I would agree with you, Amal, that we're starting to see a little bit more PEA. And in terms of the treatment of PEA, certainly it depends on the underlying etiology. There's no specific treatment. And what we're really looking for is, does the patient have a reversible cause, or really is this simply the irreversible end-stage form of shock where we're not going to get that patient back? And with reversible causes, in essence, you want to think about the fact that cardiac contraction simply isn't adequate enough to really produce a palpable pulse. So here, certainly ultrasound is going to be critical in helping us make that quick determination. But rather than think and try to memorize and pull out your ACLS card regarding H's and T's, I don't think we need to do that anymore. And it's something you've talked about a lot in national conferences and our own conference here, really helping to guide our thought process based upon the EKG and specifically the QRS complex. Is it narrow or is it wide? And there are things to think about with respect to the narrow and then with respect to the wide and then subsequent treatment. If you have a PEA that shows a narrow QRS complex, then we're thinking about obstructive or hypovolemic causes, so giving additional fluids, and then using ultrasound to quickly determine is there cardiac tamponade for which the patient needs a pericardiocentesis. Is the RV huge, and we're thinking about now TPA. Is the LV completely empty in terms of this patient? Do they need volume or do they need blood as volume? And then tension pneumothorax. So those obstructive things resulting in a narrow QRS complex. And then really two big things. There's a few others, but I think the biggest things to think about if you've got a PEA patient with a wide QRS, then you're thinking more metabolic and tox causes. And the two we've mentioned earlier were hyperkalemia and some type of medication toxicity, primarily sodium channel blocker toxicity, where we give both calcium as well as bicarbonate. And so thinking about that in its most simplistic form, look at the QRS complex, wide, narrow, and then go down your differential using ultrasound for the narrow QRS to see if you need any of those interventions.
That's even a little too complex for my brain. I keep it really simple. There is some data that QRS is not perfect, meaning there's some overlap in these two kind of phenotypes of PEA. So I tend to just go straight to the ultrasound. I think there's a few things that we can fix in PEA. By far, almost the majority of PEA we see is prolonged downtime. It's an agonal rhythm. So my goal is not to identify every cause of PEA. It's to identify the things I can fix. So I go right to the ultrasound where I'm looking for, like Mike said, tension pneumothorax, pericardial effusion, and pseudo-PEA is the big one, right? Is this someone who has a pulse? They're just so hypotensive, I'm not feeling it. And all those things can be identified quite quickly with the ultrasound machine. Otherwise, especially when you have the benefit of working at somewhere where you can do ECPR, a lot of the other things you can kind of filter right into. They're going to get put on pump as long as they haven't had a lot of downtime and they're still a salvageable patient as far as their brain is concerned. So I don't think I get beta blocker and calcium channel blockers back with traditional methods. There isn't great data that TPA works very effectively on big MIs or PE. So again, all this stuff will just get filtered right into mechanical CPR. So I no longer have to think about it as one of the things I have to solve beforehand.
All right. Well, that's a very simple approach. And I'm guessing you're going to be running large volumes of fluid in from the start. And then with that ultrasound, you can take a look at whether they're fluid responsive, which, Mike, you've talked about. You're doing passive leg raise on these cardiac arrest patients?
Not in cardiac arrest, but I'll throw this back to both of you. Say we do the ultrasound and it is more of that pseudo-PEA where there is coordinated cardiovascular contractility. So the heart's pumping effectively, it looks coordinated, can't feel a pulse. Would you go right to medicines, and if so, to butamine or epi for inotropic support, or would you continue compressions because that even though there's coordinated activity, it's still not producing a palpable pulse?
I think the data on ultrasound shows you see a lot of stuff on ultrasound, a lot of contractility. Most of it is agonal rhythm. I think for me to really think this is pseudo-PEA, I would want it to be a pretty hyperdynamic underfilled heart that is just either hypovolemic or some other issue going on. In that case, I probably would stop the compressions and go to pressors and fluid. I think the other addition, I've kind of moved away from giving large volumes of fluid to my PEA arrest anymore. And most of it is physiological reasoning in the sense that your goal is to create the highest perfusion pressure you can through chest compressions. And the big thing you're competing is the right atrial pressure, which gets higher and higher during the extent of the rest. All I'm doing with all that fluid, most of these patients weren't fluid down before they died. They just backed up. So all I'm doing with most of that fluid is just sticking it in the right atrium. I'm going to decrease perfusion, and I don't think it helps. I think we used to do it a lot because we didn't have ultrasound, and so it was one of the empiric things. Are these patients hypovolemic? Let's give them some fluid. But now I have a probe. I can put it on their chest and see. If I see a flat IVC, which is very uncommon in arrest, or a hyperdynamic heart, yes, they get lots of fluid. But otherwise, I don't really give them any fluid just because I think it's just going to make my job harder.
Moving on to post-arrest care now. Mike, this is one of the great talks that you've done at a handful of national conferences. Take us through some of the priorities in the patient once you've gotten the return of spontaneous circulation. How do you approach post-arrest care?
4 things, and just a few quick pointers or pearls, so we don't do too much of a deep dive, but I focus on airway and maximizing breathing, maximizing circulation, implementing targeted temperature management, and then getting patients off to cath who are appropriate. So what do I mean with airway and breathing? Well, if you've used an LMA, or if you haven't intubated the patient and you've got ROSC and they remain comatose, then I think that we're looking at intubating that patient. But 2 important things. Maintain normoxia, so in essence, titrate your supplemental O2 on the vent to achieve sats around 94 to 98 maybe percent. We want to avoid hyperoxia. So more and more we learn about the detrimental effects of too much oxygen. We want to target moderate saturations. And then maintaining normocarbia. So extremes of CO2 tension can be harmful for a variety of physiologic reasons we won't delve into. But we want to adjust the respiratory rate to target essentially normocarbia or normal CO2 tensions with either end-tidal CO2 or PA CO2, so somewhere around 40. In terms of the tidal volume, even though they're not ARDS, these patients are at very high risk of developing lung injury from CPR and their overall initial insult. So certainly we're going to use lung protective settings, but the big things, avoid hyperoxia and avoid extremes of CO2 tension. In terms of circulation, I personally feel that these patients, I'd like to put arterial lines in them, and I realize that not all of our listeners have that capability, but if you do, I think this particular patient population, it is beneficial because you want to be careful about titrating to a mean arterial pressure. The guidelines still say anywhere 65 to 100, a believer of a little bit higher in the immediate post-arrest setting, and our post-arrest protocol here titrates are mapped to about 75 to 80 through either fluids or vasoactive medications. In terms of TTM, certainly cooling patients, and depending on where you fall with the evidence, the guidelines recommend anywhere from 32 to 36. I'm not aware of any study that's done that range. It's either been 33 or 36, but nevertheless, cooling them, monitoring them appropriately, so that's either an esophageal probe or a bladder probe. And you can use either cold IV fluid, surface cooling devices, intravascular catheters, whichever method has not been shown to be superior. And then monitoring, if they're with you for any period of time, you've got to pay attention to sedation with these folks. Very aggressive with the sedation in terms of when you're bringing their temperature down, and then following some key electrolytes. And then lastly, in your realm, Amal, getting patients off to cath lab, certainly a STEMI, either pre-arrest or persisting, I guess, after a certain period of time, after epi wears off post-arrest, getting them to the cath lab. And then for those that are non-diagnostic, so the end STEMIs we've talked about, if they remain hemodynamically unstable, quote-unquote electrically unstable, also getting them off to the cath lab. And something that we've adopted that you've talked about before on EMCast, the algorithm from the JACC article, Journal of American College of Cardiology, with a really nice algorithm and prognostic factors. So if they lack those, then really considering early intervention in these folks. So key things: airway breathing, circulation, TTM, and finally early cardiac cath.
All right, I like that. Simplified 4-step approach. Okay. Well, one thing that really wasn't addressed in the paper that I want to ask you both about has to do with termination of resuscitation attempts. There have been a handful of recent articles over, I guess, the past 6 to 9 months that have talked about running the code to a specific number of minutes afterwards, and I think it's kind of silly because the articles have a lot of problems with them. But that brings us back to the initial question, which is, when do you terminate the code? So, Rory, let me start with you. How do you decide when it's time to say when?
So, I think the most telling data point is the initial rhythm for me. Patients who are in a PEA or asystole, again, like I said before, the most common reason is an agonal rhythm. These patients have just been down for a long time, and if they don't get ROSC within 5 to 10 minutes, their survival rates are less than 1%. So in these patients, if they come into my emergency department, they haven't achieved ROSC before they've got there, they've been in PEA or asystole the whole time, I take a look at their heart, I take a look at their lungs, I take a look for any of the fixable things that I can do to fix this PA, and if I don't find any of those, I call it quite quickly after a round or two of CPR. And I think the data supports that. The difficult patient, I think, for all of us is the ones in refractory VFib or VTAC, or who were in VFib or VTAC when someone got to them in the field and now have kind of shocked into an agonal rhythm, but they've had CPR the whole time. These are the ones that we feel are salvageable, and I think we run these codes way beyond the point of futility just because we want to fix these people. And I think in that patient, it's really hard to say when is enough, because eventually it will be, because the survival rate in those patients, if ECPR is not engaged, is about 2%. It's not very high. Most of them are still not going to get ROSC or aren't going to survive the hospital discharge. So I think eventually we're going to say is enough just because we kind of run the code to the point where we just can't run it anymore. But I think instead of saying when is enough on that patient, I think we have to agree those are salvageable patients, and we have to start looking towards other interventions to treat that kind of patient. And that's ECPR, and I understand a lot of the listeners won't have ECPR, but I think you have to start looking as a facility, what else are you going to do with these patients? Whether that's trying esmolol, dual sequence defibrillation, putting them on mechanical CPR and taking them to the cath lab. Just thinking of other kind of methods that might kind of bring some of those patients into the salvageable range, because we know they're not going to respond to traditional methods. Now, if none of that works, again, I kind of run those codes about 30 to 40 minutes or 40 to 50 minutes kind of in that area where we know whatever few patients are going to achieve ROSC would have achieved it at that point. But none of us have a good answer for that patient.
Mike, what's your approach?
I agree with everything that Rory said. The final things I would say is I do take into age some degree along with comorbidities. I probably will run a resuscitation a little bit longer if it's a younger person. And we've had a handful of folks in mid-October present to us following the Baltimore Running Festival and the marathon, and that may be something where I'll run a little bit longer, knowing the potential benefits, so to speak. Yeah, didn't even plan on that. And knowing the benefits of TTM in select patient populations, so I do take that into account, and certainly prognostic value of point-of-care ultrasound, looking for any type of cardiac activity would be the only thing I would add to that.
What I find frustrating is that you give the epi and then you get the pulses back for a little bit, and then 5-10 minutes later they start diminishing. You do compressions, you give another dose of epi, bam, you got the pulses back again, and it just becomes an endless thing. And by about the third dose of epi, you know the chance that person's going to leave the hospital with any neurologic outcome is close to zero. But yet you've got pulses back. You can't just not do anything. And it becomes very, very difficult. I'm sure you guys have had the same scenario many times. What would you do? You just stop giving the epi and maybe just use a pressor or something else? Or how far do you go with the epi if every time you give the epi, it seems like you're getting pulses back?
That's a hard question. I don't know that I can answer that because every patient is a little bit different. I think if I was getting pulses back with epi, and I'd probably start an infusion, but once again, I base it on the overall patient characteristics and what's the likelihood of them getting out of the hospital. Is it an older patient with complex comorbidities? That would play into my decision making, but I think if I kept getting things back with intermittent bolus dosing, I would just put them on an epi infusion.
Yeah, I think what Mike said is right. That's a hard question to answer. I think a lot of it is this phenomenon you're describing we've all seen, and it's in the data too. Epi gets you ROSC more often, but a lot of time it's this kind of flogging this agonal heart and just kind of prolonging its period of death. And is it really saving the patients we want it to save, or the ones that actually come back and have some kind of sustained ROSC, sustained life, and actually leave the hospital?
Right.
Like Mike said, I tend to put them on epinephrine drip almost as soon as I have ROSC. The ones that are salvageable in these patients tend to be very epi-dependent, and these big swings in epi tend to cause them to rearrest because you lose that perfusion pressure to the coronaries as they kind of drop their pressure afterwards. So almost instantly when I get people out of arrest, I put them on low-dose epi drips and kind of titrate to effect from there.
All right, gentlemen. Well, great. That was a fantastic review of pretty nice article and a really hot topic, and I appreciate your time getting us through this. I'm sure we're going to see this in LSA at some point. It's one of those types of articles. So I hope to get you guys back to talk about some other hot topics as well, and I suppose maybe in the next year or two we're going to see another update to this article, and maybe it will be all about ECPR.
Yeah, one could dream.
Well, thanks, Amal. It's been great to do this discussion with you and Rory, and certainly looking forward to our next resuscitation discussion here on EMCast.
Yeah, it's always a pleasure.
Great. Well, next up on EMCast, we're going to spend a little time talking about some infectious disease stuff, specifically blood cultures in the emergency department. And this topic overlaps not only with infectious disease stuff, but cost-effective test ordering and so on. The reason why we're going to talk about this is because there was a recent article published in Journal of Emergency Medicine that talked about blood culture utility in the emergency department, and we may not go through details of this article, but it's a good excuse to talk about this topic. And to talk about blood cultures, I have probably the perfect person to discuss this, Dr. Cami Hu. Cami has been on the EMCast before, and she is essentially in her final months of a 6-year EM/IM critical care residency. She's boarded in EM, boarded in IM, and coming close to being done with her critical care fellowship, and spends a lot of her time not only in the unit but also in the emergency department. So it's great to have you here, Cami, to kind of give us an internal medicine as well as a critical care and emergency medicine perspective on a topic that spans really all three fields. So,
great to be here. Thank
welcome
you.
back. So anyway, we'll talk just a little bit about some of the things that they got into in this article, and then we'll just get right to the nitty-gritty about when we should get cultures and how to get cultures. But before we get there, can you just talk a little bit about some background about blood cultures, why we get them in the first place, and what they mean when they're positive, how sensitive, specific they are, and so on?
Of course. So the reason that we get blood cultures is in part because we want to see what bacteria, what organism grows, what it's susceptible to, if we're on the appropriate antibiotic therapy, and how we can change our antibiotics to be the most appropriate. But I think the other big reason that we worry about it is that bacteremia itself, as we all know, has a pretty high mortality. I think they cited in the paper around a little wide range, but 15 to about 40%, which it makes sense, right? You have a lot of bacteria floating around your blood, you're probably going to be sick. So we want to be aggressive with those patients who are bacteremic and make sure that we're taking good care of them. I think one of the things that was interesting is that this paper mentioned sort of a useful culture rate, as in positive blood cultures that actually are true and change something about your patient management. And they only gave it 2.8%. So
only 2.8% of cultures are useful?
Yeah, they had a certain amount of positive. I think the number that they eventually gave was 6 out of 218 bottles in a particular study actually changed management and guided antibiotic therapy. So that came out to 2.8%. Other studies, 6% true positive rate, but only 0.18% changing management. And then as high as a 10% total positivity, but only 3.4 were truly positive. So with such a low rate of return in terms of your true positivity, and then even if you have true positives, does it even change your antibiotic therapy? It's really not as high yield as I think we've historically thought before.
Yeah, I realized it was low, but 2.8% is shockingly low.
Yeah, it was a small number of
Yeah.
patients in that study, so with, as always, hedge it a little bit, but just even with the persistent low percentages, less than 5% in sort of the studies they mentioned here of it actually affecting your management.
Sure. And especially, I guess nowadays, usually the antibiotics that we start are so broad spectrum anyway that I don't know how often they get continued with that broad spectrum upstairs. I guess cultures help narrow the antibiotics. So, why don't we go ahead and get into some of the practical stuff now? So, who is it that we should be getting blood cultures on? What are the indications and what are the patient scenarios that would make you want to get blood cultures on someone?
Well, I think the ones where you should definitely clearly get them are the most easy. Mm-hmm. The patients who are septic, especially if they're like in septic shock, patients who are immunocompromised or have sort of complicated infections. And then we really should be coming away from getting blood cultures in your very simple infections, a simple UTI, simple cellulitis, that kind of thing, especially in your immune competent patients. For example, pneumonia, I think that it being a part of one of the core measures and really be pushed by JACO, and I think everybody was up in arms about how you had to get blood cultures when you're diagnosing a pneumonia. I think this paper did a really good job sort of talking about why that's no longer the recommendation. Several studies, I think, showing that really the very low rate of positive blood cultures and then actually an equal rate of false positivity. So they quote a 2004 study where you have a true positive in 9%, but the false positives were 10%.
This is for pneumonia?
This is in pneumonia patients, blood cultures that you've got for pneumonia patients. And then, only 5% actually ended up changing patient management. Mm-hmm. the 2007 study they mentioned, a true positive in the blood cultures of 3.4%, great, but a false positivity of double that at 7.8. And they reported that out of 250 cultures, that only changed the management of one patient in that study.
Wow.
So I think we're really sort of seeing that for your simple pneumonias, especially patients not immunocompromised, doesn't have recent chemo or malignancy, no severe lung disease underlying it, that simple pneumonia, we should really be staying away from blood cultures. And a topic for another time, but looking more at our respiratory cultures if they have a productive.
Sure. Certainly, if somebody has pneumonia, you're going to discharge them home, skip the blood cultures.
Absolutely.
If somebody has pneumonia and they're immunocompromised, pretty sick, shocky, or they're going to go to the unit, we are getting blood cultures.
Yes.
What about that middle ground? What if somebody's got pneumonia, but you are planning on admitting them to the floor? What are the general recommendations for that type of patient?
I think what they specifically list according to the IDSA guidelines, which is really our benchmark, our standard for what to do in these situations, hospital admission by itself is not an indication for blood cultures. ICU admission, like you mentioned, if they're cavitary lesions, they did recommend blood cultures. Leukopenic, so one of our immunocompromised populations, if they're alcoholic, where they have severe liver disease, again, knowing that our liver disease patients are generally immunocompromised in some way. If they have, and this isn't probably going to be present in the emergency department, and if they have a strep pneumo antigen test, which is a urine test, so again, I don't know that we'll see these in the emergency department, and then if they have a pleural effusion.
So pleural effusion, you get a blood culture, set of blood cultures. I hadn't really thought about that one.
I hadn't really, and I would have to say we see so many patients who get pleural effusions that we're not routinely, at least anecdotally or by my own experience, I'm not getting blood cultures in patients just because they have a pleural effusion.
Okay.
So I think that's one of those recommendations that stands if you're concerned that they may have an empyema if they're a new patient. But I personally would have to say that I'm not probably getting blood cultures in everybody just because there's a pleural effusion. But if they meet one of these other criteria, then certainly.
All right, so we've kind of got pneumonia. You talked about cellulitis and urinary tract infections. If you want to figure out what the bug is for a UTI, it makes sense to look in the urine. What about other conditions? The article mentioned intra-abdominal infections. Is that something that we would be getting cultures on?
Yeah, it mentioned that getting blood cultures routinely in your intra-abdominal infections hasn't really been particularly helpful in changing management. I would say to kind of go with the gestalt here, in patients with a diagnosis of C. diff, I wouldn't be getting a blood culture just to do it. If they have an intra-abdominal abscess that I'm going to be able to drain and get cultures from, I would probably not get a blood culture in those patients. But if the patient, again, is particularly sick, and I think that's what we're going to keep coming back to, if they are very sick or immunocompromised, that would be when a blood culture would be obtained.
Okay. And then other infections that we often see not uncommonly, at least see in the emergency department, epidural abscess, endocarditis, meningitis. Your thoughts about those?
Yeah, I think theoretically, if your thoughts are that if you're concerned for endocarditis, then of course blood cultures are going to be what you test to sort of figure that out. Meningitis makes sense, especially in patients who you're not maybe going to be able to get that LP done before they get antibiotics. You can't wait that long. You're in a busy department. Or, if you're unsuccessful with your LP, at least you will have the blood cultures to sort of help guide you, perhaps. I thought some of the other ones were interesting. Septic arthritis. The IDSA sort of recommended blood cultures, which I agree is great. But again, if you have a septic arthritis and they're going to go for a washout, you would have cultures from that. So I think I'd be interested to see, all this. I'm sure there's not a lot of data with all of these specific cases. I don't know that for a fact. I haven't looked at it, but getting blood cultures in septic arthritis, presumptively that patient's going to be fairly sick. But if they're not, I would say I was sort of surprised that was a recommendation.
Yeah.
Osteomyelitis is mentioned. That makes sense as well. If the patient's not going to end up going to OR, they're not necessarily going to be able to get a good bone biopsy for culture. And then they do mention peritonitis, which is technically an intra-abdominal infection, but again, sort of on the more severe side. So blood cultures may be helpful to guide your therapy in that instance.
And then the latter section talked about how to order blood cultures. We've talked a little bit about who you get blood cultures on. What do we need to know about ordering blood cultures? The timing and the number and so on.
Yeah. One of the things that was a little surprising to me is that they mentioned that getting a blood culture with fever while you're having a current fever doesn't actually increase your yield. I think I'd always been sort of taught in med school or whatever that that's when you get it because that's when everything's circulating.
Right, me too.
Or on the other hand, that when the patient is rigoring is when you should obtain them before their fever. Theoretically, the exogenous pyrogens from the bacteria floating around, your body has recognized them and your hypothalamus has set itself to have a higher temperatures to kill it off. Mm-hmm. So that's why you rigor. So I haven't seen any data on that, and I'd say that would still be a great time to get them if you have a patient who is actually having shaking chills.
Sure.
There is some data out there that shows that if you have a fever greater than 38, that's a positive likelihood ratio of 1.9 of a true positive blood culture. If you have chills with your fever, then that takes your likelihood ratio to 2.2. But if you have shaking chills, rigor, that takes your likelihood ratio to 4.7. This was a meta-analysis. It was done in 2012, but I thought that was interesting. I think another thing that was interesting is that they commented on if you're concerned with endocarditis to obtain 4 sets of blood cultures, which was more than I think we usually get, right? Where oftentimes the patient's a hard stick or they're so hypotensive or hypovolemic that we're not able to get anything. We get 1 set and we're happy about it. But a little bit more in those, and that could increase your yield, I'm sure. I think is important for us is to make sure that we're getting that blood culture from a fresh stick. I know that especially in our fast, busy emergency department, sometimes we're getting the blood from an IV that we've just placed. But there is actually a little bit of data that shows if you use blood, even if you did sort of your aseptic IV insertion technique, your false positive blood culture rate, meaning blood cultures that come back with skin contaminants and aren't indicative of an actual bacteremia, is 9% versus 3% if you use a fresh stick. So 3%, and I think that's one thing that I see frequently. We're in a hurry, we need an IV, we're getting blood, we do it with the IV, but it's actually not the best way to obtain them. Also, single sampling, that is doing 1 puncture and drawing all of the blood for your 2 sets of blood cultures all at one time, or however many sets you're going to do. That's something that's not really a recommended practice anymore. The thought being that if you do have a contaminant, then you can't be sure, you don't have any way to rule out that it is a contaminant. So the current recommendations are 2 separate sites. Draw 1 set of the blood cultures from 1 stick, 1 set of your blood culture from another site and another stick.
And do they have to be separated in time or anything like that? Because, again, you learn all of these things in medical school, but you never learn any evidence behind it.
So this article didn't really look at all the data behind what that timing recommendation is for. It does mention for endocarditis that you should obtain your 2 sets of blood cultures an hour apart. I don't know what the background behind that is, but presumptively if you have an endocarditis, you'll still be positive an hour later with your heart pumping bacteria blood through your body. But they do mention also getting 2 sets in the ED. Presumptively, those could be around the same time. I don't think there's any harm in obtaining them 15 minutes apart. But I would say if you have a busy department, that patient's a really hard stick, and they were able to get those 2 sticks closer together, then that's just, I would be happy with that.
Sure.
They do mention if you get the 2 presumptively close together in the emergency department, that there should be 1 drawn later, but they don't give a specific time.
Okay. And also a total of 4 sets ideally for endocarditis to increase the yield as well.
Yeah, endocarditis, and also if you're suspecting intravascular hardware, stents and grafts, that sort of thing, if you're expecting that those might be infected.
All right, so we know the number. What about the volume? How much blood should we be getting?
This is a good question. We have all been there, the patient who finally got the stick, and then their vein blows, and you only have 10 cc's of blood, and you're like, all right, that's what I'm going to use. I mean, I think if that's all you can get, that's fair, but they do mention some statistics. So less than 5 mLs is only around a 69% positive blood culture rate, and then they really push for greater than 7 mLs, noting that there's a 3% increase in your blood culture positivity yield per ml of blood.
Okay.
And then something I didn't know actually was that they don't recommend overfilling. So you can give 10 mLs, but don't give more. And the concern there is that you have more volume and you may artificially trigger the blood culture machine to return positive faster.
All right. So just let the vacutainer suck it out, but don't push more blood into the bottle after that.
Sure.
All right. And one other thing that you had brought up offline, what about indwelling devices or lines? What do we do about that? Is there anything different?
Yeah, they recommend not actually obtaining blood cultures from the indwelling line. So whether it's a tunneled HD catheter or a port for chemo or whatnot, unless you really suspect that that's your source, they say to go ahead and avoid that. But if you're worried for endocarditis or hardware infection, then that would be an appropriate place. So you get one from the indwelling line and then another from a fresh stick at a different site.
So don't just use that line to get all the blood. Get some of it from a different site also.
Yes.
All right, good. All right, Cami, before you wrap it up, any final points you want to make?
Yeah, I think it's just really important for us in the EM and the IM side to really know when blood cultures are indicated. And it's really because as we've seen, there's a decently high false positive rate, and false positives, treating a patient based on a contaminated blood culture, it is not totally benign. So you have a patient who has a gram-positive bacteremia that is eventually going to be coag-negative staph and a contaminant. But you don't know that. So you start your antibiotics, they get vancomycin, they get too much at one point, they develop a kidney injury, and then they have problems with that down the line. That's a concern. There's cost, of course, associated with it. I think 1998, there was a Souvenir, that was the name, Souvenir et al., found a $1,000 extra cost per patient with a median increase the length of stay of 4.5 days.
Wow, 4.5 days.
Yeah.
Holy smokes.
But then a more recent study, which I think accounts for, inflation and costs and all that stuff, 2009, by Gander, noted an $8,720 increase in cost per contaminated blood culture treatment. So you have the vanc use, the kidney injury risk, but these people are also getting additional echoes. Mm-hmm. They're going for TEE to rule out a vegetation. They have to get moderate sedation for that. There are other things that can go wrong at every step of the way for something that's just a contaminant. So if you don't need to get the blood cultures, don't get them. And then if you do need to get the blood cultures, make sure that whoever is obtaining them is drawing them the right way. 2 different sites, fresh sticks, that sort of thing.
Wow, that's a really great point. Increase hospital days, increase costs just from sending off unnecessary blood cultures.
Absolutely.
It's really interesting.
And I think hopefully with the Choosing Wisely campaign, I think we're trying to get it out there, not to draw blood cultures with every little thing, but just really for the cellulitis, simple cellulitis, don't do it. Don't do it. I think if you think they have neck fash or the patient is horribly septic, okay, fine. That's an
right.
indication. Your simple urinary tract infection, even simple pyelonephritis, don't do it. Get the urinary culture.
Right.
Don't do the blood culture. For sepsis, of course, you're gonna be getting your blood cultures, but just really have good stewardship and a mind for the future.
Sure. All right. Well, great pearls. Cami, thanks so much. And we should get you back for some more topics that cross over the lines between EM and IM and critical care.
Absolutely.
All right. Well, great. Thank you again.
Thanks.
All right. Well, we're going to turn our attention to sepsis. If you haven't heard enough sepsis to this point, then I don't know what there is to say, but there's more sepsis to be aware of now. And joining me to talk some sepsis is Dr. Mike Winters. So welcome back. Recently, as you know, in critical care medicine, they have published new sepsis guidelines once again. And the article is titled 2016 New Sepsis Guidelines, although this is actually published online and is scheduled to be in print in March 2017. So this is pretty much hot off the press. It's not even in press yet.
Not in press yet. Well, thanks for having me back on EMCast.
Yeah. So what do we need to know now? I'm just going to throw it out to you, and then I'll throw some questions in also about the new updates.
Sounds good. So sepsis is something we deal with every day, I think, across the country, and all of us as emergency physicians certainly resuscitate these patients. So what we're going to do is go through the new guidelines. So as you said, these are online, going to be out in print soon. So hot off the press, what's different between these and the 2012 guidelines that we're all currently managing or using? Well, a few important things with the document itself. And before we get into the actual bedside care, I think it's important, and the authors do a great job starting off and right in the first and second paragraphs, that these recommendations, recall, are intended to provide guidance for the clinician who's caring for adult patients with sepsis or septic shock. So this isn't a PEDS document. The other thing is, importantly, these are guidelines. So they're not going to replace your bedside decision-making capability when you're presented with specific characteristics about that patient in front of you. So remember that these are guidelines, and very importantly, they state these are not intended to be standard of care. So I think that's important, and it's something that included in 2012, and I recall at that time we had discussed it, but I think it's important to just kind of get that off the bat, state that right off the bat.
All right. So all those plaintiff attorneys out there that are listening, back off.
That's exactly right. Well, in terms of the recommendations, a lot have remained the same, but there are a few critical new updates to the 2016 guidelines. So here we go. Let's talk about the topic of initial resuscitation. And for many, many years, and in the 2012 recommendations, the initial resuscitation recommendations from the Surviving Sepsis campaign were to perform a protocolized quantitative resuscitation with those very familiar targets of a CVP of 8 to 12, MAP of greater than 65, urine output greater than 0.5 mLs per kilo per hour, and then targeting a mixed venous or a central venous oxygen saturation actually of 70% and following lactate values. And that was, as we know, based upon early goal-directed therapy. Well, what is new about the 2016 recommendations is they've actually removed that recommendation for a protocolized early goal-directed therapy approach. And that's one of the major new changes with this guideline that everybody's kind of talking about. And it essentially is as a result of the 3 big trials that we've previously reviewed here on EMCast with Process, Arise, and Promise. So what are the new updates in the 2016 guidelines? Well, for the initial resuscitation, makes sense as soon as you recognize the patient, get started with treatment. They really emphasize fluid resuscitation in the initial resuscitation of septic patients. And they continue to have a strong recommendation for 30 mLs per kilo of IV crystalloid given in the first 3 hours.
Do they specify plasma light now?
So we can delve into that a little bit with respect to fluid therapy. But in regards to that, they have a strong recommendation on crystalloids as the initial fluid of choice.
Okay.
They say definitely no hydroxyethyl starches, and in terms of dextrans, they're out. They do suggest, which is a weaker recommendation, using either balanced crystalloids or saline for that fluid resuscitation.
Okay.
And we'll get into it in a minute. We'll get into that further specifics on fluid therapy and how do you know when to give more.
Sure. Okay.
But the initial resuscitation, 30 mLs per kilo of IV crystalloid. And in terms of assessing whether patients need additional fluids, we're going to focus on dynamic variables. We'll get into that shortly, but they're suggesting dynamic variables over static variables. So CVP is officially gone. And in terms of MAP, targeting our interventions to a mean arterial pressure once again of 65. And in terms of the final recommendation for initial resuscitation, normalizing lactate. And I realize there's a lot of controversy out there that's been written about what is the specific etiology of elevated lactate in the setting of sepsis. Is it beta-adrenergic stimulation? Is it liver dysfunction? Is it tissue hypoperfusion? Could be any and all of the above. But nonetheless, we do know that elevated lactate is associated with increased mortality. So the recommendations are to target normalization of lactate. So that's the big change with initial resuscitation. The protocolized early goal-directed therapy recommendations have been moved out of SSC and now really focusing on recognizing patients, starting off with fluids, targeting that MAP, and then, as we'll talk about shortly, using dynamic variables for additional fluid to normalize your lactate. Now, in terms of diagnosis, what's changed? Well, certainly we want to attempt to get as many cultures as possible based upon what we think is the primary source of sepsis. We definitely want to try to get blood cultures before we give antimicrobials. And if you recall in 2012, we didn't want to delay in getting cultures, and if the delay was going to be beyond 45 minutes, give the antibiotics. Well, the wording's changed a little bit in the new guidelines, specifically to say, get your cultures, try and get them before antimicrobials are given, whether that's blood, urine, sputum, what have you, tissue cultures, and get them only if doing so does not result in a substantial delay in the start of antimicrobials. So that 45 minutes, it's buried within the document, but in terms of recommendations, try your best to get cultures before antibiotics. And I think in terms of source control, That is also something that is very highly emphasized in terms of source control, trying to get it as rapidly as possible. So in terms of when it's logistically and medically practical, we're going to do source control. But I think specifically with respect to emergency physicians, we see a lot of patients coming in with indwelling lines. There's this specific recommendation that if you feel that the intravascular device is the source, definitely get that out.
All right. So in terms of the term source control, is really referring to where did this infection come from, and if it's something that you can get rid of, then do that.
Correct. So we're talking things about neck fash and debriding soft tissue infection.
Okay.
We could be talking about intra-abdominal abscess, removing that abscess by when it's once again medically and feasibly practical for the patient. All right, so we did initial resuscitation, some source control, we did diagnosis. Another big change in terms of the 2016 recommendations deals with antimicrobial therapy. Specifically, if you recall from 2012, in patients with septic shock, we wanted to get IV antimicrobials on board within the first hour. So that was a strong recommendation, a little bit weaker for severe sepsis and sepsis. Mm-hmm. So with antimicrobial therapy in the new guidelines, they're recommending IV antimicrobials within 1 hour for both patients not only with septic shock, but also with sepsis. So that's a key change there. Getting empiric, broad-spectrum antibiotic therapy on board makes sense. Certainly, once we know the bug and sensitivities, we're going to focus on de-escalation. But they recommend combination therapy for patients with septic shock. So this is, yet again, another important update in the 2016 document. When you have someone with septic shock, using at least 2 antibiotics that are of a different antimicrobial class. So sepsis, septic shock, get antibiotics on board as best you can within an hour. But for those in septic shock, using combination therapy, targeting the most likely organism.
Okay.
Similar, combination therapy has also been recommended in the past regarding patients with neutropenia. Well, that has actually changed in this new document, that they're recommending against combination therapy for the routine treatment of neutropenic patients. So some key changes here in the 2016 update. Some of the others are more applicable to the inpatient and ICU care in terms of the duration of antimicrobial therapy, using procalcitonin for de-escalation, and when to stop antimicrobial therapy. But I think those that we just talked about are the key ones for emergency medicine.
Okay, just to clarify, sepsis and septic shock, we want to get antibiotics on board really quick, within an hour.
Yep.
And we want to use combination treatment for both sepsis or just septic shock?
Septic shock.
Okay, all right. But you won't be faulted if you just use combination therapy.
Absolutely, you would not. But combination therapy with antibiotics of different classes.
Different classes. So 2, and they should be different classes.
Correct.
And for the neutropenic fever patient, they are not mandating combination therapy?
Correct. So you may recall in the past when someone comes in with neutropenic fever, we're thinking, well, give them an antimicrobial or 2 antimicrobials targeting, say, Pseudomonas. Uh-huh. That combination therapy or the recommended combo therapy for these particular patients is out.
Okay, unless they're in shock.
Correct.
Okay, so what would you start on a patient who's got neutropenic fever, just as an example?
So for me, I think it's some examples would be cefepime, has good pseudomonal coverage. Could be imipenem, also has good pseudomonal coverage. And then piperacillin tazobactam would provide pseudomonal coverage. But I wouldn't be adding 2 of those agents in that patient unless...
Right. So these are single agents that have broad spectrum in and of themselves.
Correct.
But you're not necessarily giving 2 different antibiotics. Okay,
correct.
I got it. All right.
2 different antibiotics towards the same organism.
Got it.
Neutropenic fever, I would give, say, cefepime for gram-negative and pseudomonal coverage, but then vancomycin for gram-positive. I wouldn't be adding 2 antibiotics to target, say, Pseudomonas or another gram-negative infection.
Right. All right. And then procalcitonin, that's a new one. Procalcitonin to kind of monitor response to the therapy.
Yeah, exactly right. So they did talk a little bit about the biomarkers that have been, the studies on biomarkers that have been published since 2012. Nothing to indicate or recommend whether antibiotics should be started. It's more on the back end using some procalcitonin regarding when to potentially stop antimicrobial therapy. But this is definitely something that's beyond the purview of patients in the emergency department and would be really applicable to those inpatient teams.
Okay. All right. Sounds good.
And before we leave antibiotics, I want to add one last thing, and I think it's a great recommendation, and that's in terms of the actual dosing of antibiotics. And they make a recommendation on paying attention to appropriate dosing. Because for a variety of reasons in the septic, or for that matter, any critically ill patient, there are changes in the pharmacokinetics, pharmacodynamics of these medications, the volume of distribution, and patients who are getting lots of IV fluids. So you got to pay particular attention to the right dose. And they even specifically state 1 gram of vancomycin is not going to be sufficient for the majority of your septic patients who are critically ill. So dosing that, they make it the recommendation on 25 to 30 milligrams per kilogram. But specifically, the point is to really pay attention and get the correct dose and choose wisely in terms of your antibiotics.
All right. Go high on Vanc.
Yeah.
All right. 25 to 30 milligrams per kilogram.
So
the
majority, most of the recommendations, the Vanc dosing is 15 to 20 milligrams per kilogram, but there is literature out there to say in the critically ill patient, your dose should be about 25 to 30 milligrams per kilogram.
All right. Good to know.
All right, so let's move on and let's talk about a little bit more with respect to fluid therapy. So in the initial resuscitation, IV crystalloids, you could choose either balanced solutions or saline, targeting 30 mLs per kilo. Now, after that initial fluid bolus, how do you know whether patients need more fluid? And this is where the recommendation of the use of dynamic markers of fluid responsiveness really comes into play. So they clearly state CVP has not been shown to be a good marker of fluid responsiveness, no longer recommended in sepsis resuscitation. Where we should be using, or what we should be using, is dynamic markers. And these are things that we've talked about before. So ultrasound, or IVC variation with ultrasound in the vented patient, pulse pressure variation, and I think what's being used more commonly, because it's applicable in both spontaneously breathing and vented patients, is the use of passive leg raise, combined with ultrasound or some method to monitor a cardiac output change. So the use of these markers to say, do patients need more fluid or do they not need more fluid? Mm-hmm. Now, in terms of vasoactive medications, our target remains the same, a mean arterial pressure of greater than 65, and they continue to recommend norepinephrine as the first choice vasopressor for patients who you're unable to achieve that MAP goal with IV fluids alone. Now, what if you're titrating up the norepinephrine and you're not hitting that target MAP? Well, the recommendations for second-line vasopressor therapy would be either vasopressin, and it's important to state that that dose is up to 0.03 units per minute, or epinephrine. And recall that these are in addition to norepinephrine. So you're not simply stopping norepi and starting vasopressin or starting epi. As you're increasing your norepi dose, you can add either vasopressin or epinephrine as second-line vasopressor therapy. Now, with respect to dopamine, we've debunked this for a while. No role for low-dose dopamine for renal protection, but they do say in highly selected patients, so ones that may be bradycardic with a low risk of tachyarrhythmias, you may consider dopamine, but I think this has really fallen out of favor in the majority of sepsis resuscitation.
Phenylephrine?
Phenylephrine? No.
Gone.
Well, it's not technically gone, but it's certainly third or fourth line at best.
Yeah, poor phenylephrine.
And the last thing with respect to vasoactive medications, and I think this is best practice, if you're using vasopressor therapy, they recommend that patients have an A-line in place for monitoring or strict monitoring of mean arterial pressure.
Okay. Did they mention anything about peripheral use of vasopressor? That's
a
hot topic.
They did not go into the use of how you administer pressor therapy, just their recommended vasopressors.
Okay.
All right, so what about the patient who you've given fluids, you've used a dynamic marker of fluid responsiveness, and you feel that the tank is full. There's still a low MAP. You've now got norepinephrine on board, and you're adding vasopressin at a stable dose of 0.03 units per minute, but the MAP is still low. What would you consider next?
Well, I recall dobutamine and transfusions were two other things to consider when people's MAP were low, depending on their labs. So
Good answer.
I would get the ultrasound out and take a look at the squeeze.
Perfect.
Okay. Good.
Wonderful job.
All right.
And if I threw in there consideration of, I don't know.
Steroids also?
Yeah, Arnold Schwarzenegger.
Yeah, I was thinking about asking you about steroids. I was holding off on that.
Okay, well, we'll get to that.
Okay.
With respect to inotropes, they do suggest adding dobutamine in patients who have evidence of persistent hypoperfusion despite fluids and despite vasopressors. So, consideration of dobutamine, that's their recommended inotrope. They do talk a little bit in a document about milrinone and levosimendan. However, they remain with dobutamine as the first-line inotropic agent. Now, in terms of steroids, great thought, and they do suggest IV hydrocortisone at a dose of 200 milligrams per day for patients who continue to remain in septic shock despite fluid resuscitation and vasopressor therapy. So that recommendation remains. They recommend against cortisone for any patient who has responded to fluids and or pressors. And I think that's based upon the recent high-press trial from 2016, basically stating if they're not in septic shock, don't give them corticosteroids.
Okay. So in other words, if they're responding to fluids, just give them more fluids.
Correct.
Okay.
Even if they're responding to fluids and vasopressors, keep going. Only if they're not responding, the MAPs are low, that's when you want to consider corticosteroids along with inotropic therapy.
Right.
Now, in terms of blood products, you did bring that up, and recall with the 2012 recommendations, and specifically following early goal-directed therapy, thinking about a hemoglobin target, they specifically recommend blood transfusion only when the hemoglobin concentration decreases to less than 7 grams per deciliter. Now, the caveat being, that's in the absence of patients who have myocardial ischemia or MI, if they're severely hypoxemic, or they have acute hemorrhage. Without those, you're targeting a transfusion threshold, hemoglobin threshold of 7 grams per deciliter.
If they do have cardiac ischemia, obviously if they're having a GI bleed,
Correct.
then you're going to transfuse them earlier.
Correct.
If they have evidence of cardiac ischemia based on, I guess, EKG findings or
could be
chest pain?
EKG and also could be positive troponins.
Okay. Would you use a higher hemoglobin threshold?
Most would use a higher hemoglobin threshold, but I don't think anyone really knows the specific threshold.
Okay.
There's some texts that would say get it above 8 grams per deciliter. Some would still use that 10 grams per deciliter. No one really knows, but in the presence of active ischemia, you would want to target a higher hemoglobin level.
Okay, makes sense.
All right, we're coming down the home stretch here, Amal, and let's just talk about 3 other quick topics. Mechanical ventilation. So when we have the septic patient who needs to be intubated, a lot of these recommendations remain from the 2012 document, specifically in patients who you're seeing with sepsis and they have ARDS. You're going to target a tidal volume of 6 mLs per kilogram. You're going to target a plateau pressure less than 30 centimeters of water. You're going to use higher PEEP strategies in these patients. And if you're having issues with oxygenation, using recruitment maneuvers. And then for patients with severe ARDS, so their P to F ratio is less than 150, they recommend prone positioning over the supine positioning. Now, that's all in the patient with sepsis-induced ARDS. What about the patient with sepsis who needs to be vented or ventilated, but they don't currently have evidence of ARDS? Well, instead of recommending, they suggest using those lower tidal volume strategies. So targeting the 6 mLs per kilo, targeting the lower or plateau pressure less than 30. The evidence isn't as robust as it is with patients with ARDS, but nonetheless they continue to suggest or weekly recommend we use the same ventilator targets.
Okay.
And I think one other pearl that often we forget about but is great is simply elevating the head of the bed. So they do recommend when you vented a septic patient, elevate the head of the bed to 30 to 45 degrees to limit that risk of aspiration and hopefully prevent ventilator-associated pneumonia.
All right. Do they say anything about the reverse Trendelenburg that you've talked about before?
Not necessarily. They don't make a recommendation with respect to that, but definitely in the obese patient where you're trying to push those abdominal contents more towards the feet rather than up and impair your ventilation, a reverse Trendelenburg position would be appropriate.
All right. Okay, good.
All right, 2 quick things, and then we're going to wrap up here. Glucose. So what's your glucose target? Well, in essence, they recommend maintaining glucose values less than 180 milligrams per deciliter. So no need to drop it real low. Start your insulin therapy somewhere when it gets north of 180 and just bring it down to less than 180.
180, not 200.
Correct.
Where did they come up with 180?
Maintained it from the prior recommendations.
All right. Okay.
And then the last thing that gets bantered about, and we probably should have mentioned this in the vasopressor section, is bicarbonate therapy. And specifically, it's a weak recommendation, but they suggest against the use of bicarbonate therapy to improve hemodynamics or reduce vasopressor requirements in patients with elevated lactate values and a pH greater than 7.15. There's not much evidence out there for patients with pHs less than 7.15. But if you've got that patient, their pH is at 7.15 or a little bit higher, avoiding bicarbonate therapy.
Right. Okay.
And that's pretty much it. So kind of just going back, Amal, I think one thing that we've repeatedly said throughout our conversation is we've used the terms sepsis and septic shock. We specifically did not mention severe sepsis, and that's because, in line with Sepsis 3.0, the JAMA article from 2016, these updated guidelines incorporate the new sepsis definitions. So sepsis being life-threatening organ dysfunction due to a dysregulated host response. They didn't necessarily get into SOFA or QSOFA. These were more treatment recommendations, but they are adopting the terms of simply sepsis and septic shock.
Got it. All right, good. Well, that really simplifies things. Some little revisions, no huge changes. So, and I think a lot of these things that you mentioned, which are, reasonable changes from the last set of guidelines, are things that we've already been talking about and largely doing over the past couple of years already.
Yeah, I completely agree. These aren't major earth-shattering recommendations. I would say that the biggest areas of change would be in the initial resuscitation and moving away from a protocolized early goal-directed therapy approach. The emphasis on antimicrobials being within the first hour for both sepsis, septic shock, combination therapy for those in septic shock, and then a lot of the other things were essentially unchanged from the prior iterations.
Right. All right. Well, thanks, Mike. I know this was a 60-page document, I think, that you boiled down to just a 25-minute discussion for all of us. So I appreciate your time. And moving forward, we'll see what future changes come up through the critical care committees and all the rest of them in the coming years. But I think this is good to start with.
Well, thanks, Amal, for having me again on EMCast. Looking forward to the next time we can discuss.
Great.
All right, well, let's go ahead and wrap it up for this month's EMCast. Just a quick summary of some of the things we've talked about. First topic was improving survival from cardiac arrest. Very nice article from Annals of Emergency Medicine, and just a few key points from that. Remember, again, the most important thing you can do early on is rapid defibrillation if it is a shockable rhythm, and secondly, good CPR, 100 to 120 pushes per minute with minimal interruptions. Number 2, remember, drugs don't work, but there is some impending or new controversy, not really controversy, but new discussion and debate about maybe early epi does make a difference. We know that increasing dosages of epinephrine during the course of cardiac arrest are not good. They are harmful, but it's very possible that maybe epinephrine truly is beneficial only in those first 10, 15 minutes or so. There's going to be more literature on that we'll discuss for sure. So we'll have to see what the literature shows about epinephrine. But we do know that the more epi you give in general, the worse the outcome is going to be. PEA. PEA is increasing in frequency. And so you need to know PEA backwards, forwards, left, right, inside, and out. 2 simple things that you can do with PEA. Look at the QRS. Is it wide or narrow? And get that ultrasound and take a look at what's going on with the heart. Fix the problem. Ultrasound is your key to fixing the underlying problem, as the speakers talked about. And number 4, post-arrest. There's 4 things to think about post-arrest. First of all, protect the lungs. Use lung protective strategies. Normalize the oxygen. Normalize the CO2 as much as possible. Secondly, focus on circulation. Shoot for a mean arterial pressure of at least 65. Probably even better if you shoot for 80 to 100 or so. Third, cooling is still in, especially with the initial shockable rhythms. That's the best evidence for the VFib arrest. Cool them to 32, 33 degrees, maybe up to 36 degrees, so you don't have to sweat it if it's just mild therapeutic hypothermia. But the guidelines are saying 33 to 36 degrees is fine. And then finally, an increasing push towards trying to get these patients up to the cath lab as quickly as possible, unless you're pretty sure it's a non-cardiac cause. It's really where the literature is going. Unless you know for sure it's a non-cardiac cause, try to push for cath lab activation. And again, this is a controversial topic that you'll have to talk about with your cardiologist because they don't want to do caths in general in patients that are going to have a poor outcome because it reflects poorly on their statistics. And unfortunately, we didn't really get into this. We've done this in past podcasts, but a lot of cardiologists are evaluated based on their cath statistics. And so high-risk patients, for example, cardiac arrest patients, they generally don't want to take. But the literature is supporting taking those patients to the cath lab. With regards to blood cultures, again, blood culture utility is very, very low. It's very rare that your blood cultures are true positives, number one. And then number two, it's even more uncommon that a true positive will end up changing your management. False positives are more common, and false positives are associated with increased hospital days and a lot more money spent on further workups. So try to limit your blood cultures to the high-yield patients. Who are the high-yield patients? Well, patients that are septic, especially septic shock, patients that are immunocompromised that are being admitted to the hospital, and patients with perhaps endocarditis, meningitis, maybe spinal epidural abscess. Those are all those patients that represent relatively high risk. There's a few other topics and patient populations that were discussed in the discussion. But again, I think we're really backing away from routine blood cultures in the emergency department. Make sure that those blood cultures have adequate volume. Remember, generally speaking, the more blood you get into those bottles, the higher the yield is going to be on picking up the true positives. And then just a few key points about the new sepsis guidelines. Not a lot has changed, but there are a couple of things to be aware of that have changed. Protocolized care, gone. CVP use, gone. Instead, use dynamic variables. For example, the passive leg raise and other things to find out whether your patient is fluid responsive. There's still a lot of emphasis on getting the MAP up above 65, normalizing the lactate, source control, early antibiotics within 1 hour, and so on. They did mention that for septic shock patients, you should be using 2 broad-spectrum antibiotics from different classes. And for routine treatment for neutropenic fever, again, if they're not in septic shock, just neutropenic fever, you don't require combination therapy, but use a single broad-spectrum antibiotics. There's also increasing discussion of procalcitonin. I'm not sure where that's going to go, but procalcitonin seems to be used more frequently to monitor the response to therapy, so it's more of an inpatient thing, and it's starting to creep into the emergency department. We'll find out more about that in the coming months and years for sure. Vancomycin dosing for patients that are in septic shock is really high, 25 to 30 milligrams per kilogram. We tend to be pretty bad about using that proper vancomycin dose. It seems to be routine to just give 1 gram of vancomycin, but that's not the proper dose. Again, 25 to 30 mg per kg in the patient with septic shock. Fluid therapy, still very important. Vasoactive agents, still very important. If the fluids are not working, again, you're shooting for a goal MAP of at least 65. The drug of choice here is norepinephrine, but if that's not working, you can add vasopressin or epinephrine. If the patient has a poor squeeze, you might consider using dobutamine. You can add some hydrocortisone if they're not responding, but no routine use of steroids for sure. And of course, if their hemoglobin is under 7, then you're going to strongly consider transfusing these patients as well. Just a few other miscellaneous points that Mike brought up was lung protective strategy. When these patients are ventilated, use a higher PEEP, but keep that plateau pressure under 30. Keep the tidal volume generally around 6 cc's per kilogram. Elevate the head of the bed to decrease aspiration, proper glucose control, electrolyte control, and again, no routine indication for sodium bicarbonate therapy when the pH is above 7.15. Below 7.15, the best I think we can say is that it's controversial. So that does it for the March issue of EMCast. Hey, one quick point before we go. If any of you are looking for a fantastic conference to attend in March, at the very end of March is the Resuscitation Conference. It's going to hit a lot of really, really high yield, high morbidity, mortality topics related to medicine, pediatrics, and trauma. It's going to be held in Las Vegas at the Wynn Encore Hotel Complex. Check out the website, www.resuscitation-conference.com. You're going to hear a lot more detail about many of the things that we've talked about, and there's some really, truly outstanding speakers that are going to be there for the 11th year in a row now. So check out the website. All right, folks, well, that about does it, and I look forward to talking to all of you next month. Bye for now.